Good afternoon, everyone. My name is C.B. Mamaril, and on behalf of the National Coordinating Center for PHSSR, we'd like to welcome everyone to the PHSSR Research in Progress webinar. We'll probably give maybe another minute or two so that we can have more of the participants and guests who'd like to join us, give them enough time to log on. So we'll start in about a minute from now. Thank you. Again, good afternoon. Welcome to the PHSSR Research in Progress webinar. And we are delighted to have with us today our presenter for today, Dr. Kaja Abbas from Virginia Tech, who will be talking about his research on priorities in rural health, cost-effectiveness analysis of fungal meningitis outbreak in New River Health District. Also with us this afternoon to provide commentary on Dr. Abbas's research is Dr. Carrie Redican and Dr. Molly Odell, both of whom will be introduced later after the main presentation. Before I introduce our speaker, I just want to let those who are not as familiar about this webinar series to know that this webinar is the fourth in a series of 10 presentations by our 2013 pre- and postdoctoral research award recipients. These awardees received small awards to complete a 12-month project with the advice and support of the center, as well as a research mentor. Recordings of these presentations appear on our website, as well as the 4 presentations by the PHSSR Mentored Research Development Awardees from January and February of this year. These Mentored Research Development Awards are 24-month awards, and these were also mentored by researchers and public health practitioners. So for those who are interested to learn more about these studies, these recordings are also available for your reference. Also in today's webinar, if you'll notice at the right side of your Adobe Connect window, there's a live poll. We hope that you'll take the time to participate in it. And it's about how you learned about this presentation. So it's just a really simple poll. Just click on it. And also, please, everyone, for today's presentation, as a courtesy to our speakers, kindly please mute your speakerphone microphone or PC microphone. We'd appreciate that very much. We'll also have some time after the commentaries are made for questions and answers. And you can also type those questions in the chat box throughout the presentation, so these will be brought up later after the comments are made. So it is my privilege to introduce to you our presenter for today, Dr. Kaja Abbas. Dr. Abbas is an assistant professor of infectious diseases in public health, the Department of Population Health Sciences, in the Virginia Maryland Regional College of Veterinary Medicine at Virginia Tech, a school that's very close to my heart. He has a secondary appointment as Assistant Professor, Department of Basic Sciences at the Virginia Tech Carilion School of Medicine. Dr. Abbas conducts research on system science modeling of public health dynamics with a focus on infectious disease epidemiology and public health and health systems strengthening. His expertise is in epidemiological modeling of infectious diseases and the economic evaluation of public health interventions and systems. So, Kaja, I turn it over to you. You have the floor.
Welcome, everyone, and thank you, Professor Mamaril, for the kind introduction. The focus of today's study is on the fungal meningitis outbreak that took place in 2012. And we are focusing the analysis on the impact of this outbreak in this local region. In this study, there are a number of collaborators on the study, and it's a partnership between the Virginia Tech Public Health Program and the New River Health District. Paige Bodwine and Molly Odell are epidemiologists and the health directors for the New River Health District. Tom Cochrane, Carrie Redican are faculty colleagues in the Public Health Program, and Nargis Dorkar did a significant part of the study. He's a Ph.D. student in the public. So in Virginia, we are located in New River Valley, which is in southwest Virginia, and New River Health District is of the Virginia Department of Health is the local health department here. The study objective is to conduct cost-effective analysis of the fungal meningitis outbreak in New River Valley local health department. The outbreak was basically caused by the pathogen Exorolium rostratum, and the symptoms included headache, stiff neck, fatigue, and also swelling of the spine and the brain, which could lead to potential fatalities. Non-infectious, and the treatment is a long course treatment with the drug voriconazole. The source of the outbreak was traced to New England Compounding Center, wherein the epidural spinal injections were contaminated. So these M.P.H injections were contaminated with this fungal pathogen Exorolium rostratum. These epidural spinal injections were administered in 23 states in the United States, and the outbreak was basically spread out over 20 states with 751 cases and 64 deaths. Virginia, there were 54 cases and 5 deaths. Response is multisectoral, right from the individual patients to the immediate caregivers, and at the clinical level, hospitals and pharmacies, and the health departments at the local, state, and the federal level. While this particular outbreak spread out a multisectoral response, the focus of this analysis is looking at the cost-effective analysis primarily only from the local health department perspective. So there are two local clinical care providers or imaging centers that administer these contaminated lots, and they were located at New River Valley and Roanoke region. And there are 94 residents in this local region who were exposed to these contaminated injections. The surveillance process that was put in place to intervene for this particular outbreak is, first the epidemiologists of the New River Health District, Paige Bodwine, basically contacted the two healthcare facilities that administered contaminated injections. And then she collected all the patients who were exposed. And then they were basically contacted primarily through volunteers to identify whether they have any of the related symptoms. If they had any of the related symptoms, they were referred to clinical care providers for lab tests, hospitalizations if needed. If not, they were followed up to 3 months every week to identify whether they had any of those related symptoms. If after 3 months they didn't show up any symptoms, they are followed up to 6 months, where they are followed up every month. And if until after 6 months since the last injection, if they haven't shown any related symptoms, then contact follow-up was stopped at that particular point. So with respect to estimate cost effectiveness of this particular outbreak, we focus on the perspective of local health department of this fungal meningitis outbreak response, and the control program that we had is primarily no intervention. Time and cost distribution shown in this particular graph in the local health department for the personnel at the local health department. Cost distribution for the different personnel is included, shown in this table, for a total cost of around $30,000. The effectiveness is measured through disability adjusted life year, or DALY. It is a combined metric of years of life loss due to premature death and years of life loss due to disability. In essence, one DALY equals one lost year of life. So what does it mean? For example, let's presume say my life expectancy is around 60, and if I die at the age of 50, thereby 10 years of life is lost due to premature death. And say from the age of 40 to the age of 50, if I'm impaired with the disability of fungal meningitis, which has a disability rate of around 0.6, in essence during this 10 years, I lose 6 years of my life due to fungal meningitis, while leading only 4 years of full quality life. So even though I live for 10 years, in essence I'm losing 4 years due to disability, or 6 years due to disability. Thereby the total will be around 16 years of DALYs lost due to this particular fungal meningitis. So using this measure, we basically looked at the case records of each of these exposed residents, and we estimated what is the years of life lost that was averted due to premature death. And it was estimated around 97 years. And we estimated the years of life lost due to disability that was again averted to around 3 years, for a total DALYs of around 105 years. Thereby, the DALYs that are averted is 100 DALYs. And the cost of intervention is around $30,000, where the incremental cost effectiveness ratio is estimated to be around $300 per DALY average. The limitations is this analysis focused primarily from the local health department perspective. Thereby, we have a partial estimation of the total outbreak response cost. In order to estimate the total cost involved in this outbreak response, we'll also have to look into the state health department, the federal department, and especially from the clinical perspective, hospitals and the pharmacies in response. And also within this New River Valley region, there is not a single confirmed case of fungal meningitis. Thereby, we use the case rate for Virginia as a proxy for potential cases that are averted in this local region. Fungal meningitis being such a rare infection, currently we do not have a disability rate directly associated with fungal meningitis. Thereby, we use the disability rate for bacterial meningitis as a proxy for fungal meningitis, since both of them had very similar symptoms and conditions related to them. So the significance of the outbreak, one, it being a nationwide outbreak. Again, in the context of there are 54 cases and 5 deaths. In this very local region of New River Valley, there are 94 exposed residents. This study basically estimated the cost and effectiveness of this response, thereby assisting the decision makers in the local health department to prioritize their. While we do not infer whether this particular response is cost effective or not, there are some recommended cost effective thresholds that are used in different parts of the world. And the United States Institute of Medicine recommends an intervention to be more favorable if it costs less than $10,000 per DALY averted, favorable if it costs between $10,000 and $100,000 per DALY averted, and less favorable if it costs more than $100 per DALY averted. And we do have some related upcoming presentations. The Nargis Dorataj will present at the M.P.H annual meeting on the same fungal meningitis outbreak economic evaluation from the local health department perspective, but she'll also add in the clinical perspective. I have a related presentation as well, focusing doing comparison of the outbreak response of fungal meningitis, tuberculosis, and pertussis. And I'd like to acknowledge funding by the National Coordinating Center for National Health Services and Systems Research at the University of Kentucky and the Robert Wood Johnson Foundation, as well as the organizer of the web webinar, and Kelly and Caesar Memorial, as well as all the participants. Thank you very much, and I'll pass it on to Dr. Kerry Redican to follow up the committee. It will be followed by more. Thank you.
Thank you, Kaja. And before I actually turn it over to our two commentators, I would like to first introduce them. Our first commentator is Dr. Kerry Redican, who has been a professor on the faculty at Virginia Tech for almost 30 years. He holds a secondary appointment as professor at the Department of Basic Sciences at Virginia Tech Carilion School of Medicine. Dr. Redican has over 35 years of experience in the areas of community health needs assessments, development, implementation, and evaluation of prevention health programs. His comments will be followed by Dr. Molly Odell, who is the director of the New River Health District, Virginia Department of Health. She's also an adjunct professor at the Department of Population Health Sciences at Virginia Tech. And Dr. Odell is board certified in family medicine with 33 years of experience in family and community medicine and public health practice, most of which has been in Southwest Virginia. So may I turn it over to you, Dr. Redican, for your comments?
Thank you. Thank you. I think it's also important to note that the efforts to deal with fungal meningitis really reflect public health best practices, especially in addressing assessment through correct analysis of data and identification of health risks, policy development in terms of written directives, with close attention to legalities and regulations, and of course assurance, with the focus being support of compliance efforts and enforcement. So I really do think that the way this was dealt with really does reflect best practices. In this particular study, the overall effort was sound with a solid application of cost-effectiveness analysis methodology, recognizing that the limitations regarding disability weight estimation of fungal meningitis. One of the slides highlights the multi-sectorial public health response to the fungal meningitis outbreak. And in that slide, 6 sectors were identified: the patient, immediate caregivers, local health department, state health department, and CDC and FDA. This study was conducted under the local health department sector, and as such really does provide benefits to the local health department. So overall, I thought it was a really fine job, and I think it provided us with a lot of meaningful information. Thank you.
Thank you, Dr. Redican. Dr. Odell, are you on the line?
I am. Can you hear me okay?
Yes, you have the line.
Great. Well, so for the New River Health District, this was a new exercise to go through for a typical outbreak investigation. And as many of you all who read the newspaper know, this fungal meningitis situation wasn't completely a typical public health investigation for an infectious disease. And so when the issue commenced and we started down the investigation path, everything that was done had to be made up as we went along, because this was the first investigation that many of us in Virginia had ever participated in that had such an important clinical diagnosis that was not accessible to the public health people. CT scans and lumbar punctures aren't our domain in the local health department, yet a lot of the algorithms around this fungal meningitis case and differentiation of who needed treatment and so forth required on some fairly sophisticated medical input. So that was a challenge for all of our staff, and to even developing the survey tool to use for all of our exposed people. So when Kaja listed as a limitation for the cost analysis, that is true, because we had to work together at the local with our state and other state partners to come up with tools that were similar when we did our investigation. But be that as it may, after the fact, we were able to go back with Kaja and his staff, students' help, and actually extract the costs that the local health department put into this investigation. And having been the first time, it was a critical exercise for our staff, because local health department staff began to see the value of their time in a new context. Many times before, staff really didn't appreciate how their piece of time connected to a whole. And so when all this was done and we presented this to the staff, we got a high level of buy-in for more research and evaluation among the frontline staff, because this piece of information validated the value of the time put in. Everyone going through the process knew how much the patients that we interviewed depended on our independent judgment and advice in the overall experience they had dealing with this highly anxious situation. The other thing of public health practice significance is, after this cost effectiveness evaluation was done, staff are much more willing and eager and meticulous about keeping their time, which has not necessarily been typical of most local health department staff in the past, to keep detailed logs of their time. So I think this exercise really informed practice as much as practice informed research, and for that reason it was an excellent partnership project. Thank you.
Thank you, Dr. Odell and Dr. Redican. Kaja, you have also time to maybe respond to their comments too as well, or would like to add anything more to the presentation too that you had?
We would like to possibly open up for questions and have a prolonged discussion.
Okay, so feel free, you introduce yourself on the speakerphone if you have a question for Kaja, or you can also use the chat box to type in your questions. So we open the floor now for questions.
Kaja, this is Ann Kelly, and maybe this is for Dr. Adele as well. I'm at the University of Kentucky, but I'm curious to hear more about how the costs were estimated or calculated by the health department staff and what tools were developed, because this is an area that we have some other projects looking at, that time studies of how people work and what they work on. So if you could give us a little more information on how the health department did that, I think it would be helpful.
Sure. We actually, in the state health department, through our MRC project or initiative, there's a spreadsheet for how to calculate the value of staff time at three different levels of complexity of worker. And so I had seen that, and as we, a couple of days into the fungal meningitis outbreak, a whole lot of it at the front end was my time explaining to local physicians sort of the medical ends of things as our epidemiologist was starting to contact the patients. It takes 48 hours to get a line list and organize your questions and that sort of thing. But in the meantime, we had people come into the ERs and physicians needed coaching. So I saw how much of my time and my epidemiologist's time it was taken. And so we had a little powwow and decided that everybody who did anything with fungal meningitis, we just asked people to mindfully jot down, even if it was on a sticky note, every day how much time they spent on it. And literally it was that unsophisticated, but I sent the spreadsheet out, the suggested mechanism that the MRC had come up with, and as a guide for people. And most people kept their time in quarter of an hour segments. And then we just told them all. And then what, of course, Kaja and his team did was take the average salary for each of the positions that touched anything in the fungal meningitis case and applied that salary, because most all of the cost was in personnel cost, time, just people's time. And we used a lot of MRC volunteers, actually, which reduced the cost of our time because they were volunteer times. So that was another thing that even using MRC time, you can still see it was a significant local health department commitment.
Okay, thank you. Did you try to value the cost for the volunteers' time?
That's done. MRC has it built in into, I don't know if Kentucky uses the same tool we do for MRC reporting, but built in the tool, it does that automatically.
Okay, and then were you able to consolidate this analysis with other parts of the state or other states' costs in relation to the outbreak, since it was a national event?
No. The other locality or the other district where there was cases didn't do anything like this. They weren't interested in that, and the state health department wished that they had done so.
Okay, thank you.
We have been able to, through partnerships with our hospitals, extract all the hospital costs for the patients, and Kaja has another presentation that he has that includes that.
Thank you, Anne, for that question. Any more questions? I would like to ask Kaja, I think for those who are not as familiar with the measures that were used, sort of two questions. If you could speak to sort of why a disability-adjusted life year as compared to, let's say, the more commonly, familiar QALY or the quality-adjusted life year. And I guess second would be, how do you put into sort of, I guess, perspective or reference you had in the slide where you gave the value of the incremental cost effectiveness ratio of $303 per DALY averted, sort of give that in perspective in terms of what that number would actually mean for, let's say, for either management decisions or practice decisions as they related to this managing this outbreak?
Yeah, sure. Thanks, Cesar. Yeah, one with respect to the use of DALY or QALY, which is, so DALY is the disably adjusted life year. The other metric that's also commonly used is quality adjusted life year. They are very similar metrics. So in fact, like DALY's averted is pretty much the same as QALY's gained. So in essence, whichever you maybe feel more comfortable, you may use it, but in essence, they are the same metric. And at least in the context of this analysis, we would have got the same results, irrespective of whether we have used DALY's averted or QALY's gained. And with respect to the second one from the perspective, first from the methodological aspect is, while in this local region, we are able to estimate the epidemiological effectiveness, the cost that is associated was only taken from the local health department perspective. There's additional cost from the clinical perspective, the cost that has been put in by the hospitals. There's additional costs associated with pharmacies, with the drugs that are administered. And also there are additional costs that are involved from the individual perspective, the time that they took off from work, and those costs are not included. And also the immediate caregivers who had to take care of these exposed patients, there are costs involved from the time taken off from work to do this caring for their exposed patients. Also, this is a response that was in partnership with other state health departments and as well as the federal. So there are multiple players in it. But so what we have is a kind of an underestimate of the cost that was involved in this outbreak response nationally. But what we do have is, with respect to the local health department, how much did it cost from their perspective? While this particular metric by in itself, while the local health department currently do not use any type of threshold to determine if it's cost effective or not, in comparison with the responses or additional public health programs, then you will be able to see some kind of a dashboard of different programs with different costs associated and different effectiveness associated, and you're able to see a dashboard of how much value gained by each of those responses to determine and prioritize among those different responses. Thank you.
So just to clarify, Kaja, in effect, the $303 per DALY averted for your incremental cost effectiveness ratio would fall under that upper right quadrant of being high cost and high effectiveness. Would that be correct to interpret that number that way?
Yes, I mean, in the sense, while we did gain epidemiological effectiveness, we also had to spend in resources. So it is we have to spend in money to get the epidemiological gain. Yes.
Correct. Excellent. Excellent. Are there any more questions that you'd like to ask, Kaja?
Hey, this is Glenn. I've got a question for Kaja, if I could.
Yeah, sure.
Hey, and again, great work. Thanks to our colleagues at New River Health District, just across the mountain here, and our colleagues at Virginia Tech for doing this great work, and to you in particular, Kaja. I guess my general question is, in your economic evaluation model, which of those parameters in your mind has the greatest uncertainty surrounding them, and did you do any work to test the sensitivity of your results to that uncertainty? And then if I could put in a more specific comment there, it seems like I wonder how much certainty you have around the epidemiological effectiveness of this health department delivered kind of case finding and case management and intervention. It seems like that parameter might have considerable uncertainty surrounding it, given the fact that you mentioned earlier that you had relatively small numbers of exposed patients and you didn't actually realize the case there. So it seems like that parameter in particular might have some uncertainty around it, and I wonder whether you've done some sensitivity analysis to see how sensitive your ICER estimates are to that uncertainty, or perhaps other parameters where you see uncertainty.
Thanks, Dan. That's a very valid point. In fact, that is one of the missing pieces in this analysis, wherein we do plan to conduct uncertainty and sensitivity analysis to determine the ranges. among the numbers that we do have, the uncertainty ranges are pretty minimal right now. So we expect it to hover around the same figure of around $300 per daily averted, but we haven't done like a formal sensitivity analysis. Thank you.
Thank you, Kaja. Any more questions? If none, I would like to thank our presenter, Kaja. Thank you so much for today, and also Dr. Redican and Dr. Odell for your time in commenting on Dr. Abbas's research. We also want to invite everyone to join us again on September 10 for another webinar. If we could have the slide of the upcoming presentations that we'll have. September 10, we'll have Brittany Johnson from the New York State Department of Health, who will present her research on improving HIV/STD partner service performance in New York State, a performance management approach. So we would like everyone to be able to join us, and also please refer to the other presentations that we have scheduled for this series. And we look forward to having you join us again soon. Anne, Kara, is there anything that you'd like to add?
This is Ann Kelly. I think when any of the participants receive the email reminder about future webinars, if you click on the box that allows you to add that appointment to your calendar, then I'll be able to send you the slides in advance of the call if that's something you'd be interested in. So if you have any other suggestions on how we can improve the webinars, please feel free to email me or Kara, and please respond to our poll about how you heard about the webinar. Thank you, and we'll see you on the 10th of September. Thanks.
Thank you, everyone. Have a great day. Thank you.
Thank you, everyone.